So first, I just want to welcome you all today to our 2023 annual Enhancing Community Resilience to Improve Maternal Health Workshop. It's an honor to stand here before you all today as we gather to talk about increasing access to maternity care services. More than 2.2 million women of childbearing age live in maternity care deserts that have no hospital offering obstetric care, no birth center, and no obstetric provider, according to a 2022 report from March of Dimes. The organizations featured here today are meeting that need in their communities. We are here for a common purpose to enhance our understanding of the life-saving work that community-based organizations are doing in the maternal health field, share knowledge, and forge partnerships. We are joined by a diverse group of experts, healthcare professionals, and advocates, all of whom share a deep commitment to improving maternal health outcomes. I would like to express my gratitude to the event organizers with us today, our sponsors, our speakers, all who helped make this workshop possible. Without further ado, let us begin this workshop by hearing from our keynote speaker, Dr. Bayo Curry-Winchell. And I am going to share some information about Dr. Bayo as well. Dr. Bayo holds the esteemed position of Medical Director of Community Engagement and Health Equity, where she spearheads initiatives related to diversity, equity, inclusion, and belonging. Additionally, she serves as the Medical Director of Urgent Care Clinics at St. Mary's Regional Medical Center in Reno, Nevada, and is the visionary founder of Beyond Clinical Walls. Dr. Curry-Winchell's profound commitment to her community extends beyond her primary roles. She also assumes the role of medical director for the Washoe County Sexual Assault Response Team, offering crucial support to survivors of sexual assault. Her dedication shines as she volunteers as an assistant medical examiner at Washoe County Child Protective Services, ensuring the welfare of vulnerable children. Throughout her career, Dr. Curry-Winchell has been honored with numerous awards, including the prestigious 2022 Healthcare Heroes Award from Nevada Business Magazine. She has also been recognized with the Community Service Award by the Washoe County Medical Society, the 2021 Young Physician Award from the same society, and the 2020 PBS Reno Spotlight Extraordinary Neighbor Award. Her remarkable accomplishments extend beyond the local arena, with accolades such as the Sierra Nevada's Top 20 Most Powerful Women Award in 2019, and her recent recognition as one of the 75 Black healthcare leaders to watch by Becker's Hospital Review. Dr. Curry-Winchell has also served as the president of the Washoe County Medical Society and has had the privilege of being a two-time TEDx presenter. Her expertise and insights are not confined to her medical practice. Dr. Curry-Winchell actively participates in national media interviews and consistently contributes to various publications. Outside of her professional endeavors, she finds joy in the company of her husband and their two young daughters, relishing life in the picturesque surroundings of Reno, Tahoe. We will welcome Dr. Bayo to the stage.
Thank you very much. I'm just going to look for the clicker. Sorry for that. Perfect. Thank you very much. Thank you. Well, let me kind of lift that up just a little bit. Well, thank you for the beautiful introduction. I am incredibly honored to be here. Yes, my name is Dr. Bayo Curry-Winchell, which is a long name. So occasionally when working with pediatric patients, I will say curry like the spice and Winchell like the donut company. So you can call me Dr. Spicy Donut, which usually goes over pretty well with little ones. Like a spicy donut, I am a blend of many things. I'm a family medicine physician who practices urgent care. I'm a medical director for the urgent care system and a medical director for Washoe County Sexual Assault Response Team. I wear many hats in my healthcare profession, but my passion is health equity and health literacy. I always seek ways to reduce health inequities and disparities for historically excluded people, those often referred to as underserved or marginalized, which usually includes people of color. People often ask what fuels my passion for tackling such an overwhelming, challenging, and complex issue. For me, the answer is simple. My passion comes from my father, William Curry. He was a remarkable 99-year-old man who served in 3 wars: World War II, the Korean, and Vietnam War. He was a man who always kept a positive outlook while simultaneously advocating for equal rights and better treatment for all. And despite his service to our nation through 3 wars, like so many, faced obstacles when trying to access equitable, quality healthcare. He often felt dismissed, unheard, and left frustrated. When the March for Moms and AFP approached me to speak on maternal health, I was deeply honored. This conference presents a significant opportunity to shed light on the barriers moms, birthing peoples, and families continue to face each time they seek maternal health care. It highlights ways to advocate for change to improve maternal care. It gives a platform for our voices to be heard by a broader audience so we can shed light on the inequalities we currently see in maternal health care. In this country, with a robust healthcare system, a system that often people declare as the best in the world, we have one of the highest maternal mortality rates in the industrialized world, meaning death during pregnancy, childbirth, and within 1 year of giving birth. In fact, according to Statista, only Costa Rica, Colombia, and Mexico have a higher rate. But that is for the US as a whole. Unfortunately, the US climbs to #1 if you look at certain groups within the US, not groups with a particular medical condition or specific age group, but rather these groups are impacted by all too common threads, which includes racial discrimination, clinician biases, and limited access to care. Now, access to care is usually what people end up focusing on. It's often what is thought of as the main issue. However, this is not simply an issue caused by limited access or lack of resources. The maternal mortality rates of Black mothers are from many interconnected factors. Today, we'll explore maternal health from a new perspective that will include the history of maternal care in the US, race-based medical practices, and the role of unconscious bias. I will share insights into ways we can collectively address the disheartening statistics that continue to plague maternal outcomes. I'll provide practical tools for empowering patients and share the vital role that family medicine physicians play in maternal care. Before delving deeper, let's pause for a moment and reflect on the high-risk labels often associated with specific races, conditions, diseases, and health outcomes. So I want everyone to think about, back on the slide, think about conditions like hypertension, diabetes, and kidney disease. Is there a particular group or race that comes to mind? What about maternal mortality? Now let's take a moment and reflect on why. Why do certain racial groups experience a disproportionate burden of disease, chronic illness, and poor maternal health outcome? We know Black and Hispanic women are 3 times more likely to die from pregnancy-related causes than their white counterparts. But why? So the next slide, I want you to take this in because whenever I share this information, people are taken aback. So race, when we talk about race and we talk about how it impacts more than other diseases, I want us to kind of think about how it is widely believed that a person's race influences their susceptibility to certain diseases. I distinctly recall my time in medical school when I was taught that being Black was linked to a higher risk of diabetes, hypertension, or kidney disease. This notion always left me with a profound sense of curiosity, especially when I reflected on the concept of race itself. Race is a social construct, meaning it's something that humans made up. It has no biological basis. While I identify as Black, It's important to understand that my skin color doesn't define my ethnicity. Being Black doesn't mean I'm African. In our current healthcare system, categorizing race as a risk factor for disease is an unsettling reality. To understand how race influences the delivery of maternal care, we will start with some historical events that help shape people's views on healthcare to this day. So, when we think of history and racism, it's important that we look at in the 1930s, Puerto Rico's doctors pushed women into sterilization, claiming it was the only means of contraception. This program was so effective that by 1956, 1 in 3 Puerto Rican women had been sterilized, taking the choice of parenthood away from 1/3 of Puerto Rican women. Next, the Tuskegee syphilis study, which was a government-sponsored program that tricked Black men into suffering the terrible symptoms of syphilis for over 30 years under the guise of a treatment plan. A study that watched them slowly deteriorate from a disease while having penicillin readily available. Events like these are a stark reminder of the consequences that healthcare mistreatment has on the perception of public health for generations. Now let's go back a little further. In the 1840s, Dr. James Marion Sims, still known as the father of modern gynecology, developed some of the surgical tools and techniques we still use today. Sadly, he did this by experimenting on enslaved Black women without using any pain medications, assuming they did not feel pain. He took this so far that one of his patients, an enslaved 17-year-old Black girl named Anarcha, was operated on 30 times in 4 years without pain meds. Shortly after these experiments or tortures, Dr. Sims started performing his surgeries on white women with pain medication. These events are often dismissed as long ago and not pertinent, or we don't do that anymore. But these events are passed down through generations. And for me, some of these events are just one generation away. In my role as a family medicine physician, I frequently encounter firsthand accounts of how these historical events significantly shape a patient's decision-making tree. These experiences not only influence whether they seek medical care, but also deepen their mistrust in our healthcare system. Stories and beliefs passed down through generations hold tremendous power. They have the capacity to shape our perspectives and impact how we interact and perceive the world around us. Dr. Sims' legacy serves as a poignant example of how these historical events can have far-reaching effects. The very same events that may lead a Black patient to approach doctors with caution can conversely contribute to a white doctor's belief that Black patients do not experience pain in the same way, which was recently shared in a 2016 study published by the Proceedings of National Science, which found 40% of medical students believed Black patients did not feel the same pain, that our nerve endings were less sensitive, that we had thicker skin. These beliefs, ingrained over time, have the potential to persistently influence future generations and plays a significant role in the disturbing statistics we witness today in maternal health outcomes. Shockingly, studies have shown that 60% of pregnancy-related deaths are preventable. And a staggering 1 in 6 women report feeling disrespected by healthcare providers during pregnancy. Another contributing factor to maternal health outcomes is medical bias. So what is unconscious bias? It's the social stereotypes that we form on our own without realizing it. It's those gut reactions to how people look, talk, and behave. Now, it's important to understand unconscious bias in and of itself is not a bad thing. In fact, It's something we all have. However, it's a phenomenon that it operates beneath our conscious awareness. Yet, it has profound implications in healthcare and beyond. When healthcare providers, healthcare systems, and healthcare policies harbor biases, whether conscious or unconscious, it can lead to unequal care, treatment, and diagnosis. These biases can give rise to profound health inequities and disparities, perpetuating a cycle where certain populations consistently receive suboptimal care. This inequitable treatment may manifest as delayed diagnosis, barriers to accessing quality healthcare services, and overall disparities in health outcomes. Unconscious bias significantly influences the delivery of healthcare services today. In fact, I had a firsthand experience. I had just finished delivering my second child via C-section, and it was about 30 minutes, and I knew I did not feel the same way as I had before. And I remember sharing with my nurse, something's wrong. And she said to me, Bayo, everything's fine. Your vital signs look normal. You're fine. So I waited a little bit longer. And then I still didn't feel right because I was having a hard time talking, speaking, concentrating. And so I reached out to her again and she said, nope, you look completely normal. So then I asked my husband, who was at my bedside, to call my doctor. And I had his cell phone number in my phone because physician to physician. He came over and he knew something was wrong and he heard me. I was taken to the OR and I was bleeding internally. And I was transfused 4 units of blood and I was hospitalized for 2 weeks. I share this story because it's important for us to look at. I had the most access, I had everything, and I still was not seen. So when we talk about biases and we talk about these outcomes, it's important that we know that they play a role in healthcare settings every single day, contributing to the disparities faced by Black mothers. My case, like Serena Williams or Tori Bowie and so many others, was not the result of limited access. These are deep-rooted issues in the fabric of our healthcare system that needs to be addressed. But it is not just conscious and unconscious bias. The healthcare system contains several systemic race-based medical practices and policies affecting lives every single day. Now, we have all heard about race-based algorithms, and I'm going to dig a little bit deeper and provide more information. So, often we hear that Black patients are more susceptible to kidney disease. And there's a marker that we use called GFR, and it stands for glomerular filtration rate. It's a test we use today to assess kidney function and disease. And the predominant practice is to add a marker for Black patients that shows their kidneys as being healthier than non-Black patients. This marker makes no sense. Black kidneys and white kidneys are exactly the same. And a lot of people don't know that a white person can donate to a Black person and vice versa. This practice leads to poor health outcomes for Black patients for no other reason than it's what has always been done. And when I share this, people say, well, what's the harm? Well, I'm going to share the data. eClinical Medicine Journal found it is keeping 31,000 Black Americans off the kidney transplant list. It is preventing 300,000 from qualifying for a nephrology referral and keeping over 3 million outside the threshold for stage 3 chronic kidney disease. Imagine the impact of inaccurate kidney diagnosis on pregnant mothers and the risk that it can cause in pregnancy. Next, let's talk about VBAC. So when we talk about delivery and pregnancy, it's important that we highlight the type of deliveries that are available. So of course, there's two types. We have, of course, the medically preferred method, a natural vaginal birth, which has fewer risks, faster recovery, and significant benefits for the child versus a C-section. However, in the early 1990s and 2000, C-section rates considerably increased across all races, one of which was to decide what can we do to decrease the amount of C-sections. So then they decided to put into this play the scoring system, the VBAC. So the VBAC score was started in 2007, and it evaluated if you had the likelihood or probability of having a successful vaginal birth after a C-section. This assessment asked 4 questions, and these are 4 questions I want you to think about. The first question was, what is the patient's age? Because older moms may have more risk. The second question is, what is the height? Because the bone structure of more petite women might not allow a bigger baby to come through. The third question that was asked, is what's the weight? Because heavier women may have more complications. But the last question that is asked, is the patient African American, Black, or Hispanic? The scoring system disregarded every other race and ethnicity. So imagine you have 2 women with the same age, height, and weight, and with equal risk. One gets to choose a natural birth, and the other goes into a C-section solely based on the color of her skin. Now, when I share this, people often think, oh, the scoring system was removed in 2021. Yes, but let me share this piece. The National Institute of Health shared that it takes 17 years for new evidence to translate into standard clinical practice. So today, this scoring system continues to impact maternal health outcomes for women, birthing people, and families every day. So what can we do to make a difference? To make real progress in reducing maternal mortality disparities, we must go beyond the notion of expanding access to care and take the time to dissect the many layers that contribute to these inequities and disparities. These layers encompass systemic racism and unconscious bias, race-based medical practices, and the limited representation within our healthcare system. Each of these elements plays a pivotal role in shaping maternal health outcomes and addressing them comprehensively. This is essential to creating long-lasting change. Yes, I'm always behind on the slides. Yes, representation matters. Increased representation within all healthcare teams is absolutely critical. Recent studies have shown that states and counties with a higher number of Black doctors have witnessed significant improvements in the life expectancy of Black residents. In fact, having Black doctors in the medical workforce has been linked to a 10% increase in the life expectancy of Black patients. This evidence highlights the vital role of when patients see healthcare professionals who look like them and understand their unique experiences. Trust is fostered, communication improves, and disparities in care begin to break down. It's also important that we highlight the role of family medicine physicians in maternal care. We are uniquely positioned to address this crisis in our role as advocates to improve maternal health outcomes, and we should be leveraged. We are trained in maternal care. We have the expertise to provide comprehensive care, from prenatal care to delivery and postpartum care. Also, family medicine doctors are trained to take care of the whole family, which includes both mothers and babies. We are often the anchor of coordinating all care at so many different levels and ensuring team patient-focused care is at the forefront when we go with our patients, placing us at a crucial position to inform them about the disparities in maternal health outcomes and empower them to speak up when they feel misunderstood or dismissed. So in closing, I have a couple of pieces that I want you to take with you. First, it's important to take the time to reflect internally and examine your own biases. Recognize how they may influence the care you are providing and the current health policies in motion with your organizations or healthcare systems. My personal experience is an important reminder that even with optimal access and medical knowledge, that did not prevent me from almost dying. I implore you to remember that our journey towards achieving better maternal care and closing the healthcare gaps relies on fundamental acts. First, asking questions. Next, remaining curious. Then, actively listening to the stories that reflect the realities of maternal health outcomes. Take a moment to reflect on the reasons you believe these disparities exist. Then set aside preconceived notions based on race, gender, ethnicity, or social economic status. It's through this process of introspection and acknowledgement that we can truly comprehend the depth of the issue, gaining insight into the unique needs of mothers, birthing people, and families. This understanding brings us closer to addressing the numerous gaps within maternal care, gaps that manifest as complications, poor outcomes, and the heartbreaking loss of lives during a time meant for giving life. Thank you. I was supposed to have And my favorite part is questions and answers. I love to connect, and please, if anyone has any questions, I'd love to answer. It's a heavy talk, but it's a talk that I'm proud to bring forward. Any questions? Yes. Absolutely. And that's when I talk about, because right now the current climate is, we're talking about all the amazing healthcare professionals that bring forward to the table, doulas, midwives, and so forth. The difference that I add to it is we have to talk about, even if you have a diverse healthcare team, if that team is biased in any areas, you can't improve. And one thing that I always talk about is, if you didn't listen to the patient, are you going to listen to the doula? Are you going to listen to the midwife? And that's the part we forget. And that's the part that we have to keep advocating as a team, that biases happens in all areas. So even if you have the most diverse team, but if that diverse team has biases within it, we're not moving the needle. Yes. You start young, and so they can see doulas, so they can see physicians, they can see nurses, and see that this is an opportunity that, yes, you can do this, and continue to foster it. And so I think that's the part where people will go into school systems and they'll go once. No, you need to keep going. I'm still here. I want you to see me, and I want you to see me in different mediums, so you know there's an opportunity to do it in any sector that you can. And I think there's also a piece that we forget, whether you're a physician, a nurse, a doula, you can provide care in so many different ways. And so really being able to reach out, whether it's through the clinic, community, television, social media, let them know that we are here. And that's why I do what I do, because I'm like, I want to hit every pocket. So every kid of color or adult knows that you can do this and you can make a difference. Yes. Mhm. Thank you. I appreciate that. And I also, I add that this happened at a hospital system that I'm the medical director at. I've been there for 10 years and this happened to me. Yes. Absolutely. And I'm going to provide some information. So when I talk about race-based medicine, because when I was creating this talk, I was like, oh, there may be wondering why I'm talking about race-based medicine, and I'll share why. So to your point, we're all trained, whether you're a doctor of color or not, to know these race-based practices. And so we have to infiltrate and disrupt that piece, because if you don't, they are going to continue to deliver that and not allow the birth justice to happen. I'm going to give a more concrete example. Right now, for high blood pressure, there are 2 classes of medications that are recommended if you have high blood pressure. And there's 2 if you're Black, not the rest. And so imagine if you are coming in and you have high blood pressure, your doctor is going to give you 1 out of 2. You come back 3 months later, doc, my blood pressure isn't under control. Okay, let's keep trying. You come back. Well, let me give you this other medicine versus all of the other medicines that could have controlled it. 5 years, 10 years from now, we know high blood pressure not controlled leads to kidney disease, heart disease. We can't get a kidney. We are disproportionately impacted right now of heart disease and kidney disease. Let's follow that loop. If I can't get access to all of the other drugs because of the color of my skin, how am I going to be able to be at an equal playing field? So those are the pieces that currently doctors of color and doctors of not color are putting forward. And I was in a webinar about 1.5 years ago where a doctor said, oh, if the patient is Black, we need to put them on this medication. So that's why I highlight these race-based practices, because whether it's someone who's pregnant, whether it's someone who's thinking about being pregnant or not, all of these elements that make up who we are need to have equal access to care, whether it's treatment or prevention. Yes. So these are the 2 pieces that I start with, because first, I'm acutely aware it is hard to feel comfortable talking to someone where there's this position of power. And so I often say, lean into saying, I would like first you to tell me why you picked this medicine or why you picked this. And you might actually hear, well, you're Black and these are the rules. And this is what you might actually hear that. And the reason why I like to start with that, because now you kind of know where that person's coming from. Or it could be, oh, I just thought this was the right thing to do. So that way it allows that doctor, because a lot of doctors are not coming from a bad place. They may be coming from a place of what they learned, or they may be coming from a place that's not good. So if you can kind of set that field, and then when you say, I don't feel like you hear me, I don't feel like you're listening to me, and using those words where I don't feel like you're doing this, I think that allows or fosters dialogue so that person can feel like they're not being attacked. But if they do not respond appropriately, that's when I say you reach out to another doctor. And also informing yourself, because there's so many different areas of health literacy, but it's hard to go nowhere. But the more you know, the more you can actually help yourself. And I have a free, as Rebecca knows, I have a series on Instagram and TikTok. It's all free. I release content on anxiety, menopause, hypertension, diabetes, 2 minutes or less. That's digestible. It's informative, and it'll gives you something to walk in when you have a loved one that has a health problem. So check it out. It's completely free. It's on Instagram, dr_BCW. and patients are using it. And it brings me joy of when, what should you ask for before you go into surgery? But then I also infuse underserved, people of color, all these inequities, things that we may not know about as far as race-based medicine. They can. And so that's a good piece too. But one thing I'd like to kind of disrupt is that health advocate, have they had unconscious bias training? And the other thing I like to say, often people will say, we have training. Well, I want you to unpack that training and retrain again. Because the training could be based on, you think as a specific group, we're at high risk for certain things. So there's no harm. Well, there is harm by not continuing to unpack, disrupt, and make sure that your clinical team, your policies are truly infusing unconscious and conscious bias. Any other? I love this. This is my favorite part, Q&A. It's a heavy talk. There's a lot to digest. An hour from now, you'll be like, oh yeah, she said that, let me. And you can reach out to me, DM me. I never mind. So please feel free to DM and ask questions. That's what I'm here for. And I share, as a Black female physician, I represent less than 3% of physicians in the US. A lot of times people don't know that number, although the Black population is over 14%. So we have work to do. And, with the current climate of different things, as we know of the rollback, we've got to continue to advocate for healthcare professionals in all areas of color. Well, thank you so much for having me. It was an honor. And if you want to learn more about race-based, there's 2 TED Talks out there. Again, they're free. It's titled Do No Harm on YouTube. Please check that out. And the other one is Why Don't Black Patients Trust the Healthcare System? Both are TED Talks that are live that share more information that could help you or someone that you know.